So, my name's Michael. I'm a doctor based in the Midlands and Nottingham born and bred, living in Leicestershire, work at UHDB, and originally went to university at the University of Lincoln. So, about as East Midlands as it gets, but also do a lot of work in the West Midlands and London and Liverpool as well. By background, I'm a doctor based over at Royal Derby, and I also do half a day a week at UHDB as their associate CCIO. So it's a great privilege to be amongst everyone else in the community, and I'm really pleased to be a part of it. My sort of training program took a weird spin during COVID because I actually left training to start an industry role. So I founded a company that looked at increasing the digital maturity across healthcare services, both in the public and private sector, both in the UK and internationally. So part of what our team now do is managed services, but mostly around digital and data. So we have a bunch of engineers that go in to organizations, new and old, and support them with increasing their innovation capabilities, change, digital transformation. So Kevin and I thought it'd be a good idea to talk around digital maturity. What does it actually mean, and how do we implement it in an organization that doesn't have, disposable income, shall we say, and also, obviously with the workforce always at capacity, everyone's extremely busy. How do we influence change? So that was really what I wanted to come and speak to you about today. And I guess it's coming from the lens of the junior doctor, someone that has worked on the front line since being 18 years old, started out as a HCA. So that's a bit about me. And I have done an MBA as well for my sins. So without further ado, I'll dive straight into it. So I've got the slides up top, but what I'll do is I'll just talk through them. So whenever we talk about benefits realization, the first thing that we do as Bloom is always look at the kind of current state of the art. We do a lot of work in community and home care services, and everyone has a digital transformation strategy that's probably 3 to 5 pages long, but is deliverable over 3 to 5 years. So that's a page per year, and it's probably not going to be that followable. So we look at actually where do we want to get to in 1 and 3 years, and then work backwards and really trace back those KPIs. Now, when it comes to innovation, when it comes to change, we often look at what the definition of change is. And for me, it's change occurs when the pain of staying the same is greater than the pain of change. I'll say that again in case it was a bit of a tongue twister. So change occurs when the pain of staying the same is greater than the pain of change. And I like to use this when we come to doing particularly things like training and education, Connor, because I know that's something that you mentioned. And ultimately, we know, across the NHS that getting clinicians, wider healthcare professionals to engage with training is really difficult because they are thinking, I'm just here to do my day job. I don't have capacity to even think about anything else outside of that, particularly when it comes to e-learning, which typically has poor compliance. So what we try to expose is the pain of staying the same, and really understanding the size of the impact that it's having on our clinicians, on our workforce, and then how much of an impact that new innovation is going to have. Now, this doesn't have to be something that we procure. This doesn't have to be something that costs money. It just needs to be better than the pain of staying the same. And so this is a really nice, easy way for us to articulate the way in which we look to do digital transformation and increase digital maturity. I think one of the things that we've lost sight of actually is the undercurrent of things that need to happen alongside implementation of a new UHDB, for example. We're just going through a core EPR procurement. It's a huge piece of work. But with that comes all of the other things that, like Connor said, training and education, communication. I think communication, again, is something that we don't do well enough across the board, because the methods that we use typically are traditional, email, for example, which we do more to protect ourselves, to showcase that we've got a paper trail of communication, as opposed to actually ensuring that there is a good hit rate in terms of how many people have opened that email. Because let's be honest, if you're seeing an email from the trust, you're deleting it to find the ones from people, so that they're the ones that you're going to focus on, because they're the ones that are going to require a response. And that is a behavioral problem that we need to overcome. So we look at other inventive ways to be able to communicate with the wider workforce. So obviously, typically things like WhatsApp can be appropriate in many cases. And that's some of the things that we look at, whether there is a bespoke communication tool that some of the EPR providers or their sort of allied ecosystems can offer up. And so I think this is one of the other things that we particularly look to bring in as an undercurrent to the actual digital transformation itself. In addition to this, I'm just going to try and see if this comes up. Any remarks actually at that point in terms of when it comes to benefits realization and change management? Are there any experiences that people want to surface while I try and get access to my slides?
I'm looking for hands, but just to say, Mike, I really like that articulation around the pain equation.
Mm-hmm.
That's that's really nice.
Yeah, it is. And the Wi-Fi is not working, so we are ad-libbing to the end. So change management is the key one. The undercurrent of training and education is the next. And I'd say the third one that is a big one is regulation. Now, obviously, having been on both sides of the table, both as a vendor and as a purchaser, a client, if you were, I think regulation is something that we avoid. And again, another cheesy tagline is, if you invent the ship, you invent the shipwreck. And this is something that I tell a lot of the mentees that I mentor in industry on the NHS England Clinical Entrepreneur Program. It's that we as SMEs, as startups, don't take regulation seriously because they're so focused on benefits realization, return on investment, things like that. So we as NHS leaders are therefore really, really responsible for ensuring that the governance around regulation is tight. I think it's really important that we actually hold our vendors to account. And I'm saying this because I know what comes from that in terms of the requirements. But it is really important. And I think if any good company should have their governance in place. So when it comes to things like DTAC, ask for it at the start. Put my NHS hat back on for a moment. One of the things we find is that clinical safety actually isn't a rate determining step in procurement, and it should be. So that's one of the key drivers that I'm having in UHDB, is that we have a stop moment where we look at the DCBO 129 from the vendor and our DCBO 160 to make sure we have clinical safety in place. Because a solution, not that this has happened in UHDB, but a solution should never even have a go live date until we know that the clinical safety is in place. It can have a estimated delivery date, as we like to have in the NHS, but it should never have a definitive go live date. And I know that causes problems with finance. I know that causes a problem with PMO, but ultimately clinical safety is bound by law, and we need to be respectful of that and wary of that. So whenever I'm involved in a procurement, the first thing I ask for is their clinical risk management file, because we know we can start to digest that. If they don't send it to us, then that's a serious red flag, as well as all of the other things that IG need around the DPIA. And a lot of this stuff is becoming automatable now. So I actually came across a solution that enables templating of DTAC documents and things like that as well. So that is on the market. And I do think that the market is becoming more aware of the regulatory compliance requirements. And part of my role at UHDB is looking at how we make that more effective over the vast amount of solutions that we have. So I'm actually looking at creating some templates and just layering in some automation so that we can start to populate things like the hazard log with some of the more generic risks, and then we tailor the additional risks to that specific product. So that's just one of the things where we're doing internal innovation at Derby and Burton. Yeah, I've got a hand from Alistair.
Yeah, I just thought, are you happy to take questions as
yeah, let's go for it. Yeah, let's go for it.
So do you get this scenario as well where people come to you going, yeah, it's regulate, either they don't think about regulation at all, or they kind of, their response to the safety element is, oh yeah, it's regulator approved, it's got its CE mark, or it's and that's kind of, they think that's the end of the conversation.
Yeah, I think they are expecting you to be too busy to actually follow up on what you're asking. So the hope is that they just give you the DTAC checklist and it's like, there you go. And then you take a look under the bonnet and you might not be happy with the quality of the documents that they provide, because ultimately it's the document quality, not whether or not they've actually completed it, because they could write 5 lines and say they've completed a clinical safety case report. So yeah, you definitely need to look under the hood, because ultimately, the patient's on your watch. The manufacturers should obviously be liable, but at the end of the day, it's never not going to come back on us as the care provider. So I think we do owe it to our patients to be extra cautious with the value, the quality of the documents that were provided. So they were my 3 key points around how we increase digital maturity. I just wanted to now touch on actually how we increase digital maturity and some of the clever ways that, as an entrepreneur, as someone that's built innovation, we've managed to introduce value into the NHS. So the first one has been quite an interesting case study around, I mean, it's simple, isn't it? It's the bathtub analogy. The only 3 ways that we can increase capacity within a hospital that's bound by 4 walls is preventing people coming into hospital, reducing the amount of time that they're in hospital, and then having an effective and efficient discharge. And I did say the word efficient. I always get called up on saying the word efficient. It's frowned upon in the eyes of the NHS. But if you hear me out on the definition, you might agree with me that efficiency is increasing productivity without compromising quality. And I think that is digital health innovation in a nutshell, right? If we are able to deliver efficiency, as in more productivity, so seeing patients faster, having better patient outcomes without compromise of quality and safety, then that is efficiency, and that is what we see as value. So then it comes to value for money. How do we actually demonstrate financial benefit? Now, that's really hard to do before a patient has gone into hospital, because now we're practicing preventative medicine. So I have a real issue with how we demonstrate value for something that prevents a cost being incurred. So because ultimately you've got to sell that to the NHS Trust, and as CTIOs, we need to be able to feel that benefit that's, quite frankly, out of our realm, because the patient hasn't even landed in our A&E or in our vet bureau or in our GP practice yet. So I'd be really keen to hear how you have had experiences where you've procured preventative medicine and what that looks like. Are there any examples that come to the top of your head, just so that we can sort of discuss it? If not, I'll move on to the next bit. That's great. So as we expected, no one is buying preventative medicine at the moment. Cool. So then you've got shortened time in hospital. So this is where the virtual space comes into play. Now, so we do a lot in virtual wards and virtual care, trying to keep patients out of hospital, trying to keep hospital patients moving out of hospital in a friendly fashion. And we're really starting to see some really great things in the industry around even taking it to the next step of hospice in your hospice at home, or virtual hospice, whereby we're able to treat patients that are typically in a care place for a long period of time, and provide them with the same treatment, the same level of care that they might expect from a hospital or a hospice. So again, this is obviously a capacity builder. It is still, believe it or not, quite difficult to quantify the cash release and benefits with things like this, because ultimately, bed blocking historically has been a way to save money, because if you've got one hip in a bed for a month, it's cheaper than having 10 knees in a bed over the same month. So again, it's difficult to demonstrate cash release and benefits with some of these cases. And it's also the same with creating efficiency and productivity actually in the hospital, because typically as an NHS, we don't sack people. So saying that a solution saves 4 or 5 FTEs of resource, if you've got the workforce gap anyway, fantastic. You can argue that there's an opportunity there. But if you've already got significant resources and they're just not able to meet the demands, then it's difficult to say that there's an FTE release and benefit there. So again, these are some of the challenges that I'm bringing to you from my experiences within industry, because I think it's a really different perspective to what we discuss within the NHS typically, and we sit around the table thinking about. Yeah, I know, but the recruitment isn't quite working either. So it's a tale of two halves, isn't it? Um, so virtual care. So I've spoken about digital training and education. I won't touch on that too much because that's already been discussed. Um, Digital communication and how we transform the way that we communicate with patients, how we communicate between staff to staff, and how we communicate between hospital and staff, hospital and hospital. I think is really interesting. Um, just another case study. Actually, there was a challenge where I learned that there was this outside of UHDB. There was query STEMIs being sent to cardiology consultants for PPCI via WhatsApp because, of course, ambulance services don't use the same systems as we do within the trust. So there's a massive interoperability mismatch there. And obviously, we shouldn't be using WhatsApp. Well, it depends who you ask, but generally, we shouldn't be using WhatsApp for anything. But I know there's counter arguments to the same. I don't think we should be using WhatsApp for anything. I don't think it's safe. I know that they've put face recognition within WhatsApp now, but I still don't think it's a good way of transferring data. So because you can't see who sent what. But anyway, that's by the by. So actually, how do we transfer data from one system to the next, something like an ambulance service to a hospital trust, and who pays for what? There's a big political issue around that. Again, there was another system whereby we wanted to create emergency buzzers that you gave to ambulances that had patients, A&E patients, sat on the forecourt, and we didn't know who was responsible for that patient because they're sat in an ambulance services ambulance, but they're on the grounds of the hospital, so they belong to the hospital, but they are under the care of a paramedic who doesn't work for the hospital. So again, politically, when it comes to increasing digital maturity, we've got a real challenge there. So I've just kind of thrown several ideas, thoughts, and feelings around the challenges around increasing digital maturity within the Midlands. Just speaking about the Midlands in particular, we have a wealth of opportunity here. We have some fantastic hospitals surrounded by some fantastic universities, and we've got the academic health science networks, or as they're now called, the health innovation networks, that we should be engaging with as clinical entrepreneurs, whether we're NHS staff or not. We should engage with these teams to actually support us with driving efficiency and driving effectiveness within our hospitals. So if you haven't met the health innovation networks, they're well worth meeting with. They will help you organise webinars and seminars, and they'll also help you with potentially, embarking on internal innovation. Alistair?
Yeah, so one of the things that I've observed in terms of different trusts around the country trying to kind of digitally transform, as it were, is just that a sense of being overwhelmed by the number of opportunities. So there's a mixture of, I think what often happens is that there's companies beating to your door saying, oh, we can, normally with quite, massive claims about what they can do for you, the kind of millions of hours they can save. So sometimes it's coming from a kind of, oh, this sounds interesting and attractive, rather than necessarily a strategy in terms of actually what do we need as a health institution. But I guess my question was, what are there kind of core products? And I think it'd be quite interesting if you're happy to name individual products where you say, a bit like we might all grumble about Teams versus Zoom versus, Google Meets, etc. Is there experience you can share saying, okay, this, if you're going to do one thing, it would be this, and I'd go for this particular platform. If it's the next thing, I would do this, and so on.
Yeah, I mean, it depends on the use case. I mean, having explored the market for a few years now, there are multiple teams that do the same thing. And I think that is good for competition. We don't want again, there's a big argument in the industry around having a monopoly or a duopoly when it comes to electronic patient records. So, if everyone has applicants or Cerner, is that a good thing or is that not a good thing? I don't think it's a good thing. But I do think when it comes to solving more specific problems, so things like virtual wards or lab-based, movement of cancer biopsies, for example, these are all issues that aren't solved by a single EPR and therefore need to go to market. I think it's really difficult to pick a preferred supplier because ultimately everyone's use case is so different, even from trust to trust, because it ultimately depends on what the core electronic patient record is, whether or not the solution integrates and interoperates well with that solution. So there's not a best, like a gold standard ecosystem within any one trust because of the way that we bought software historically, which has created it's effectively where we're at now financially and operationally. We've got some real challenges in terms of having joined up care because we've got such non-joined up solutions. So I think that's one of the challenges, Alistair, is that it's really difficult to give a best of breed supplier for each of the certain things. I mean, if you asked me who my favorite virtual ward supplier would be, I would give you three because, again, each of them just do slightly nuanced things. Are we caring for a patient from a community care provider versus a secondary care provider? Do they need to integrate into certain types of remote patient monitoring devices and things like that? So it's a very political answer, but I think once we understand the use case, and this is why the outline business case is so important. Once we understand actually what we're trying to achieve and good architectural mapping of the systems that we currently have in situ, it becomes a lot easier to identify how we increase that digital maturity.
Thanks, Mike. You happy to take more questions? I don't want to interrupt your flow, but
absolutely, yeah. Any other questions? Yeah, Jeffrey.
Hi, thanks. I kind of missed my moment potentially. It was a bit before when you were talking about DTACs. I'm interested in specifically kind of AI-enabled tools. And one of the use cases I'm looking at, and it's often the case, is only one or maybe two kind of products on market for a particular use case. And something we've experienced is trying to kind of negotiate with those companies which have mainly got a European strategic focus. And when you sort of ask about completing DTAC and things, certainly at the initial kind of pre-procurement levels where you're just trying to scope things out, they're pretty dismissive or trying to sidestep those. Do you have any kind of advice or tactics about how you can point out a way that would be easier for them to do it? I know you mentioned some kind of templates and things like that, or any other kind of strategies that come to mind would be great to hear.
Yeah, so I think if you're getting friction with a vendor that is requiring DTAC, I think that the starting point is to hit them with the template documents because that is, they're readily available on the NHS website and there's no excuses for them not being able to find it. I think one of the common misconceptions is that if a solution is a software as a medical device, that it's got a CE mark or a UKCA mark and that satisfies the clinical safety aspect. But actually, the challenge is that we obviously like to see certain documents in a certain way. So the technical file of a CE solution or a UKCA marked solution doesn't actually represent the same. It has a risk assessment, which you can convert into a hazard log. It has clinical evidence reporting, which you could convert into a clinical safety case report. But it is apples to pears. And I think that the hard work is done in a lot of these medical devices. If it's not a medical device, then there's no excuse because these are documents that they should have in place anyway. If it's not had a hazard identification workshop or it's not had any kind of thinking from an internal clinical safety officer, then we really should be avoiding it. So my advice would be speak directly with the clinical safety officer. If they don't give you a name, then that's a red flag. And if they do give you a name and you have a consultation with them and they then say, what's clinical risk, then again, that's a red flag. So I do think, you know, we've got all of the tools in our armory because we do know about clinical safety. It's one of the things that as CCIOs we're geared up to because we know about informatics and we know about clinical care. So I do think you can tease it out of them. And if you are getting any friction, do let me know because there's nothing more satisfying than going to them and trying to tease out the DTAC documents from them. And get IG on your side as well from a data protection and a cyber security perspective. IG and IT should be able to tease out, you know, whether or not they're kind of trying to pull the wool over your eyes. And I guess that's one of the benefits of these framework agreements, that they should have performed some of this due diligence with you. And I say should, because actually now I think about it, we've just been appointed onto a framework and they didn't ask us to demonstrate in great detail our DTAC documentation. So there's something to be said about that. I won't tell you which framework it is on that basis. But yeah,
Thanks
it's
very much. Really helpful.
it does go to show actually that it's really important that you always just check under the bonnet and make sure that you know seeing is believing. Thanks, Jeffrey.
Mike, just on that, one of the things that we say, so our team supports our trust, University Hospitals Birmingham, in all the AI deployments. So basically around process, medical algorithmic auditing process, so that the any AI deployments are kind of evaluated in terms of their sort of performance, but also looking across different groups. So we're checking for equity as well as kind of majority or kind of average performance. One of the things we say in that context is safety is not an optional extra. And the idea that you can just deploy something out of the box and it will, particularly, you know, technologies that are machine learning based, the idea that it will just start working happily and exactly in the same way as it did on its kind of previous test site. So I loved what you said about the kind of making, you know, not letting a deployment go live until the safety is all signed off.
It's that what I said there was true regardless of the solution. I think when it comes to automation, I mean, automation is only as good as the foundation that it's laid upon, right? And particularly the data quality that it's laid upon. And so I think one of the key things that we want to see, and I certainly want to see with any solutions that are either in the market or being tested or being deployed in the NHS, is that human in the loop. I think right now there are very few clinical tools that can truly operate without a human in the loop. If you found one, fantastic, let me know. But I do think that the human in the loop, for example, you know, happy for an appointment letter or a clinical referral to be generated by generative AI, but I've still got to read it, sign it off, and make sure that it has all of the accuracy and it's in there for my colleagues. So that is one of the things that I think is important, and we owe it to ourselves to make sure is that with the vendor, there's an iterative process to get into truly automatable or fully automated processes. So take that stepwise approach with them, especially in the vendor's early days, you know, drive a hard bargain with them, get them to do some pilot site testing. You know, no one should be really transferring any kind of or significant financial remuneration for pilot site testing and early adoption because you're both going through it together. You know, they're benefiting from you using the solution as you are them because they're gathering that evidence, they're gathering that accuracy and hopefully reliability. So take advantage of that and get them to hold your hand all the way. Get them to, you know, ensure that it's not, you know, having downtime or it's becoming unsafe or that its accuracy is going up and definitely not stagnating or going down. So these are just some of the things that, having been in industry, I expect our clients to come to us and ask for, and trying to instill that into the NHS so that we can not stifle innovation because that's how we get more digitally mature, but also, but just hold each other to account between the two sides of the table, I presume, I suppose you could say.
Yeah, no, I think that's a great point for those who are kind of on the call who are making these kind of decisions. The companies will come to you saying we've got a solution and you can have it at this cheap rate, you know, the kind of standard or discount rate as an early adopter. But actually do realize that, you know, this is a partnership and actually you are a really valued partner in terms of being able to provide that critical data. But I mean, that's a really good thing to be doing. I'm actually just going to hand back to you, Mike, in a moment. But you reminded me there's a new funding call out, which is an interesting one. It's coming through the NIHR. But what's interesting about this is it's a joint call, or jointly funded, between NIHR, the Office of Life Sciences, which is like the government sort of innovation arm for kind of life sciences and health, and NICE. And what this is for is that there are a number of technologies, often mainly digital, that are that have had what's called an early value assessment by NICE, which is almost like giving the device the L plates. It's saying, well, we've got most of the evidence we need. We think it's safe for you to deploy, but particularly around cost effectiveness, there's still evidence we need you to gather. And so this call is funding for quite, I can't remember if the top level is 5 million or maybe more, but funding to basically do real world studies. And they're inviting partnerships between the technology provider. So there's a list of, I think, 59 different technologies on their list that are eligible. Then a sort of academic site to coordinate the design and coordinate the trial or the real world evidence gathering, and then multiple clinical sites. So it may just be worth keeping an eye out and potentially seeing if any of those technologies are of interest. We're happy to sort of connect people if via Kevin, but also if any of you are already planning bids, do shout, and again, we can try and connect people to each other. Sorry, back to you, Mike.
So that's very serendipitous, actually, Alistair, because I literally was just about to mention funding. When I was speaking about pilot site testing, I think this is one of the things that we really need to be taking advantage of as NHS organisations, because as a public sector organisation, you have access to lots more pots of money than industry does, and therefore you can do internal innovation, and yeah, you can start to almost set up research hubs for industry to come and do some testing, and guess what? No one has to pay for it, which is always nice. I guess the main thing to think is what you don't want it to be too sticky, because then when the money runs out, have you still got that value for money that we want to see? There was a message in the chat by Ian. Really good question, because you are right. People get caught up in intellectual property. People get caught up in commercialization when it comes to innovating within the NHS. And my response is, you never saw a hedge fund do an inguinal hernia repair, because I think this is the other thing that we have is that NHS trusts are not commercial vehicles. They need to be sustainable, but they're not there to sell stuff. That's not their job in the current infrastructure setup that we have. Jackie Rock recently announced that she wants to commercialize the NHS, and it'd be interesting to see what she means by that. But there are really sustainable ways to actually to make sustainable projects. So we worked with a lot of our NHS trusts to help them distribute it outside of their trust. So if they're finding value, we go and look at other trusts to see whether or not there's value there, and we then go and we ask them how much is it to license this, and then we sell it.
Right, this has been absolutely brilliant. Well, first of all, are there any more questions for Mike? We're sort of coming into land time. Very appropriate, given where you are, Mike.
You, so yeah.
Yeah. Any questions? But otherwise, Mike, do feel free to share any other pearls of wisdom, and we'll come into land.
Yeah, no worries. That's fine. That was my closing remark on that. Really, it's a crying baby, so it's probably best if I take any final questions.